those of you who are here, just to have a quick orientation, this is part of a lecture series that we have that is interdisciplinary, supported by the Evidence-Based Practices Institute and the School of Social Work. And the kind of meta theme that we have is evidence-based practices for what, for whom, and how, right? So no small task. We have a series of lectures that we give throughout the course of the academic year, and the complete lecture schedule. And also we videotape all of our lecture series. So, for example, something today interests you and you want to share it with colleagues, there'll be videos in the next week or two about the lecture that's up on the website below. And I can put this back up again after Dr. Prinz's talk today. And here's the website as well. Our next lecture is going to be on December 8th. And Aaron Lyon's going to talk with us about implementation of evidence-based practices within school-based health center settings. And so we're really looking forward to that as well. We'll post that information on our website, and we'll probably be back in social work, which is where we typically hold these lectures, for that one as well. But without further ado, I would like to introduce Dr. Ron Prinz. He's a Carolina Distinguished Professor in Psychology who directs the Parenting and Family Research Center at the University of South Carolina. He attended UCLA in California, University of California at Berkeley as an undergraduate, and had his doctorate in clinical psychology from the State University of New York at Stony Brook. He's the lead editor of Clinical and Child Family Psychology Review, and his research focuses on parenting and family issues, population-based prevention of child abuse, and the prevention of childhood behavioral and emotional problems. He was the lead investigator for CDC-funded U.S. PPP system population trial, and directs the Research Consortium on Children and Families at the University of South Carolina, and an NIH-funded T32 research training effort called Behavioral Biomedical Interface Program. In addition, he was my research mentor in graduate school, so I'm very happy to have an opportunity to introduce him for this lecture. Let me get your slides up here, Ron. So please join me in welcoming Ron Prinz.
Thank you. Well, and Sue, thank you for arranging Occupy Seattle. It just brings back my days at Berkeley. Okay, I'd like to sort of introduce to some of you a different paradigm about parenting and family support than what most or almost all of us in the parenting intervention field have been doing for years. There's another way to go about it that's begun to emerge. And that's true of other areas as well besides parenting intervention, that we can take a population approach. But a lot of people go, well, what does that mean? So what I'm going to try to do is make that come alive for you today. Let me just quickly acknowledge the various entities that I'm involved with, or that have provided some grant support as well, and get into the session because I know time is limited. I'm going to talk briefly about what a public health approach is relative to taking a population approach, and then quickly get into what might be the elements then for a population approach to parenting and family support. I'm going to use the PPP system as an example of that, and then talk about the prevention of child maltreatment, which was the ostensible goal of the U.S. PPP system population trial, as an example, but use that as a jumping off point, and then we can have some discussion about just this whole strategy. First of all, what distinguishes a population approach from other paradigms, other strategies, such as clinical approaches or high-risk approaches or targeted prevention approaches and so on, is that we define the outcomes of what we want to do in terms of whole population. And we target primarily prevalence reduction, or you can also put it in positive terms of prevalence increase for positive dimensions. So it's not necessarily only about reducing adverse issues. And it takes on the quality of the intervention or set of strategies are designed and implemented in such a way as they're intended to impact at a population level. Now, I would contrast that with some people come up with a very good program that will work with this family or this classroom or this particular targeted unit. And when they say taking it to scale, that's not exactly synonymous to what a population approach is. Usually when people say take it to scale, they mean just do it with lots of those units. Now there's nothing wrong with that, but that doesn't capture the essence of a public health population strategy, which is if you're not just working with individual units, but you want to reach collections of units, what else do you need to do, or how do you need to engage differently in order to make it cost-effective and practical to reach the whole population? Because just taking for example, an intensive intervention that you would do with one unit, and just doing that intensive intervention with lots of units might not be practical. It might be ideal in terms of replicating the effects, but it may not be attainable. It may, there's other side effects of trying to do intensive things with everybody. So keep that as a backdrop, that there's a different mindset, and it comes mainly from public health. I'm a psychologist, a clinical psychologist by training. I had no background in public health, so I've picked this up over time just from listening to and reading the ideas from public health-minded researchers and practitioners. Now, the parenting and family intervention area is late to the party when it comes to population approaches, when you think about the whole notion of public health. Here are the top 10 public health achievements in the U.S. identified by CDC. And you don't see parenting intervention in there. There's some family-related things, but they're not focused on parenting per se. So, for example, with coronary heart disease and stroke, there have been comprehensive strategies developed over time, and the result has been, since 1972, a decrease by 51% in death rate for coronary heart disease. Similarly, for motor vehicle safety, there have been public health population-wide strategies that have helped to reduce fatalities and accidents. So what might a population approach to parenting and family support look like? How many of you have heard of or are familiar with the recent IOM report on prevention in child? Anybody? Okay, a few. Okay. I think it came out in 2009, I believe. In that, you'll find some of the key points include endorsing a population health perspective, which wasn't emphasized much in their previous report in the mid-90s, and providing families, for example, with easy access to evidence-based preventative interventions, but minimizing stigma. So that's a key qualifier. How do you provide lots of families with access without having the act of participating be associated with stigma? Okay, so my thoughts about a population approach are that you want access to parenting support to be there for all parents, not just for a sliver, not just, for example, for new expectant mothers living in poverty. That's not making it broadly. If that's what you have to do in order to get support, most parents are out of luck. They don't fit that criteria. We need to help those mothers too, or those prospective mothers. But that's not reaching the whole population. So we need cost-efficient strategies, and that means trying to make use of other things besides just face-to-face delivery, media and communication strategies, to augment and contextualize the interventions. and then using it as a principle to give parents the minimally sufficient support to help them promote healthy child development. In clinical psychology, I was taught, throw the kitchen sink at every family. Okay? Well, first of all, many parents don't want that. Secondly, many of them don't need it. And thirdly, it can backfire and can cause people to drop out prematurely, or you're simply wasting resources. So we need to think more strategically. In medicine, they don't recommend that everybody gets surgery for every problem. They have a whole array and series of steps that somebody might consider. The physician and the patient consult and try to figure out what would work best, taking into account the patient's preference and what might help solve the medical issue. Well, we need to be smarter in the intervention area with parenting and families and make use of those kinds of principles. There need to be, in order to improve access, you need to have several different ways and places for parents to get support. And I think, given the theme of this lecture series, I don't think I'm preaching to the choir too strongly, that to insist that programs be proven effective before being disseminated. Now, there are some programs outside the parenting and family area, for example, such as DARE and some other things that have been widely disseminated and actually had pretty good population penetration strategies, but they weren't evidence-based. So there's a case where they were dressed to go to the prom, but they didn't have a date. It wasn't appropriate to be disseminating something in a population level. Now, let me focus specifically on Triple P as an example. I've worked with a lot of different evidence-based parenting programs. I've created my own kinds of programs that I've done on home visitation, in a home visitation model. But over time, over many years working in this field, I gravitated towards Triple P. And it's predominantly because of the public health approach. It has other attractive features to it, but that's what attracted me. I've known Matt Sanders for over 30 years, but I've been more involved with research on Triple P probably for the last 12 years or so. So I have a context in which to judge what it brings to the table. The focus of Triple P is primarily on the prevention of children's social, emotional, behavioral, and I would add health problems, and the prevention of child abuse and the strengthening of parenting at a population level. And in terms of target populations, it's built around a theme of being useful for all parents. Not that all parents need heavy doses or need face-to-face, but it's couched in normative, non-stigmatizing language and examples. But it's really a blending. From a prevention standpoint, it's a blending of universal, selected, and indicated prevention. People like to refer to Triple P as a universal approach because it's full of population. But it's technically, universal would be like a vaccine. If you give a vaccine to everybody, well, that's a universal intervention. But if you have a multi-tiered thing in which some people get some parts of that tier and other people get other parts, that the whole system is universal, but the pieces are not universal. In fact, you don't want them to be universal. So it's this blending notion. And of course, blending doesn't fit very well with the people who like to put programs into boxes. So this one sort of busts the sides of the box. I should also mention, it also has utility in treatment contexts as well. So in the child and family area, particularly with younger children, there's a nice continuum of prevention, early intervention, and treatment in which the parenting strategies can be used preventatively as well as after problems have developed. But that's true of more than one parenting intervention. So this is just a repeat. At the top of the slide, a repeat of what I just said. when you disseminate the full system, the idea is to use the existing workforce in many different settings serving parents. It's not, you don't want to have to hire specialists to deliver Triple P. You want to make use of many different disciplines, many different sectors of the workforce, again, to expand access and make it so that parents can choose where and with whom they want to get programs. It's a multi-level system, and I'll go into that a little bit more in a minute. Now, it's associated with a pretty big evidence base. But actually, it's been going on for more than 30 years. It did not acquire its name until mid-90s. It wasn't called Triple P, but the forerunners of Triple P were being developed by the Sanders Group. And then in about year 2000, the University of Queensland, in joint venture with Triple P International, began to disseminate Triple P actually globally. And what a lot of people don't know is Triple P is not owned by the developer. It's owned by the University of Queensland. And they have charged Triple P International with maintaining quality assurance. And much of the funds that get generated off of dissemination of Triple P go back through the University of Queensland system down all the way to the department and center where some of this research has been conducted. So it's not your classic program where a developer develops something and then starts a company and goes off and disseminates it. That's oftentimes not apparent. Now, and the population trial actually was closer to 2009. This arrow should be. Well, I'm sorry, maybe they're thinking about an earlier population study. There are two population studies that I'll mention. That was right around just a few years ago. But if you look at, there have been to date, by 2011, close to, or over 200 papers, but 175 evaluation studies. Across all of these studies, there's a fairly consistent pattern that the various components of Triple P, tested in isolation and sometimes in combination, increase positive parenting, reduce coercive parenting, and lower social emotional behavior problems, and improve parent-child relations. So there's lots of different studies that have contributed to that. There's some that are observational, where there's parent-child observation. Most are not, because they're out in the field where it's not practical to ask parents in community settings to go through systematic observation. And there have been many randomized trials, a lot of efficacy trials and some effectiveness trials on different levels, variants, and components of Triple P in many different settings with diverse populations. And over 270 investigators have conducted or authored studies related to Triple P. So it's a broad network of researchers and practitioners around the world that are working on this. Two critical population level outcome studies have been conducted. One is called the Every Family Prevention Study, which I'm not really going to talk much about today. And then the population trial that I led, that I'll talk more about. Now, Triple P has all of the attributes associated with evidence-based parenting and family interventions more generally. And these include things like being theoretically driven from multiple theoretical perspectives, but nonetheless you can identify pieces within Triple P that come from certain theoretical foundations. They're action-focused, not just talking about ways of parenting, but actually helping parents do things with their child. They're problem-solving oriented, not simply abstract, but trying to get at specific issues that need to be solved. That there are specific parenting strategies, and this is true of all of the well-evidenced parenting interventions. There's collaborative goal setting. It's consultative rather than prescriptive. And there's an adoption of a positive frame. Even if the parents have gotten in trouble for child abuse, there's still an attempt to frame the work in terms of how to build on assets, how to, for parents to bring out the best in their children, and to take an optimistic, we have a problem, let's see if we can figure out how to get out of the problem and get to a more productive outcome. Some additional attributes of triple P, the obvious one is the multi-level, in other words, in varying intensities, and that there are several different delivery formats for triple P, and then that there's a major emphasis on self-regulation, on children acquiring self-regulatory skills, but this is explicit rather than implied, and the parent becoming more self-sufficient in promoting their own improvement in parenting rather than being completely dependent on a practitioner, having to show them everything that they need to be doing or tell them what to do. And then the practitioners that are trained in triple P are not under some kind of external force. The idea is that they are in charge of their own professional development. And then trainers of practitioners similarly. And then the way agencies and organizations and the community are treated in terms of how triple P operates. There's this notion of that people and groups and the community need to be the architects and the controllers of their own destiny. Now the 5 levels refer, the names are sort of, sometimes a little bit of a misnomer, but universal triple P is primarily media and communication. Selected triple P is very brief, 1 or 2 contexts in different formats, but very brief. Primary care triple P does not have to be in a primary care health system. It just means it's short enough that it would fit something like a primary care system. In other words, where there isn't a more extended treatment regimen. Standard triple P is more classic kind of parent training and parenting intervention, and enhanced triple P are things you can do in addition as part of the parent training and parenting intervention approach to strengthen the intervention for parents who need more. There is a common set of principles that underlie all aspects of triple P, and it turns out in most cultures around the world, parents and community leaders will articulate facets of all 5 of these. They play out maybe differently to some extent in different cultures, but parents want their children to survive. They want them to be safe, and they want them to be engaged with the family. And if you want children to succeed in the world, you need a responsive learning environment, but you can't be an effective parent without needing to use disciplinary practices in an assertive but positive way. So you can't neglect that principle, but you need reasonable expectations about what a child can do, not just developmentally, but different children at the same developmental level progress at different rates, and so you need to set your expectations in terms of what a child is already able to do, rather than assuming they can do much more than they've developed. And then the parent needs to take care of themselves in order to be a more effective parent. We're not suggesting that they should be martyrs. The parenting skills, these are 4 classes of parenting skills in triple P, sort of like a menu, and what's not reflected here is there's a developmental flavor to how different parenting skills play out for different age children, and some of these skills go away and are replaced by other skills that parents need as children, to deal with older children. But basically the four categories are promoting a positive relationship, teaching new skills and behaviors, encouraging desirable behavior, and managing misbehavior. And within those, there's lots of choices, and you help a parent match their preferences and their style with options of things that have been demonstrated to have some positive impact. And you get them to acquire, particularly the longer deliveries of Triple P, to acquire skills in all four of these areas. When I work with parents and they have a serious behavior problem that they're trying to manage, and they want to deal with the management of misbehavior. Well, it turns out that much of the secret to managing misbehavior is what you do when the child is not misbehaving. But most parents caught in a cycle don't know that, or don't see it, or don't know how to get out of it. So much of managing misbehavior has to do with how well you encourage the opposite of misbehavior, but you still need that management strategies too, because that in itself doesn't get rid of all the problems, particularly if you've got long-standing habits. Now, let me switch to child maltreatment. I want to make sure I leave enough time for questions and comments. First of all, we know that child maltreatment is a big risk factor for all kinds of problems in later childhood and adolescence and adulthood. And there have been a number of studies that have documented this thoroughly. And almost 95%, in one study, 95% of maltreated children showed problems in middle childhood and early adolescence. That's a very high rate. But here's the catch. Official child maltreatment masks the true extent of the problem. Let me show you how badly it masks it. First of all, is child maltreatment rare? Officially, yes. Unofficially, no. What's the underlying problem that makes us even care about dealing with child maltreatment, in addition to wanting to stop the most serious cases that lead to fatalities and severe injuries? Is that parenting practices undermine child development and all the things that go with that undermining. So efforts at prevention need to take a broad approach and not just focus on the very narrow sliver of parents who officially are tagged as having engaged in child maltreatment. There was a study by a group in North Carolina. They did a random telephone survey in 2 states, and they found that based on parental self-report, anonymously, the incidence of physical abuse derived from their reports was 40 times greater than the official records, okay? And in those communities. Now, even if that's double in terms of exaggeration, maybe it's only 20 times greater, it's still a huge occurrence of child maltreatment-related behaviors that don't come to the attention of the authorities. In a telephone survey that our group conducted, this was with random dial telephone, a survey of 3,600 families where there was at least one child birth to 8. Half of them reported heavy reliance on discipline strategies for child misbehavior that at best could be considered ineffective and were mostly coercive in nature. So that's the norm. And here's the kicker. Remember now, this is self-report, so this is probably an underestimate. 10% reported they spanked using an object on a frequent or very frequent basis. Because that was their first line of defense, was to grab something and hit the kid with an object. That's much higher than the prevalence of official child abuse. So in this population trial that we conducted, We wanted to prevent child maltreatment at a population level, focusing on children birth to 8. And we used a design called place randomization. Normally, randomized trials that you're familiar with are clinical trials where individuals sign up for a trial and are randomized to treatment conditions or intervention conditions. That's the usual randomized trial. In my whole career, I'd never seen a place randomization trial in psychosocial kinds of interventions. Closest thing that you could find to that is maybe randomization of schools, right? But it's still not quite the same thing. Has some similarities, but a lot of differences. So we took counties, and I'll explain the design in a minute, and randomized them to condition. We trained the existing workforce of service delivery providers, many different disciplines, and but thereby created multiple access points for families. And then we implemented all 5 levels of the Triple P system, including the media strategy. So there were 18 mid-sized counties. None of these in South Carolina, none had prior exposure to Triple P. The counties were picked geographically, but they weren't recruited. It's not like when you do a clinical trial and you have people come and sign up and you have to advertise and whatever. We just looked on the map and then we randomized. And when we randomized, we actually controlled for child abuse rates, because the counties didn't all have the same child abuse rate, poverty level, and population size. Because even though they were all mid-sized, they still had some variation in population size. And then we randomly assigned them, matching on those variables, to get either the Triple P system or to be the comparison of the control counties. The control counties, just services as usual. And we didn't go to a county and say, oh, you're a comparison county. We just left them alone. Okay? And we didn't go to the intervention counties and go down the street to a parent and say, oh, you're part of a place randomization trial. We simply trained a bunch of workers in there to do this as part of their service. So unlike a clinical trial where you can only talk about the people who signed up for your trial, everybody in this population with a child birth to 8 was automatically in the trial. There was no attrition. The only way you could have attrition is if a county put barriers at the borders and wouldn't let us come in to train workers, which they didn't do. So we had 5 years of pre-study baseline, and we ended up with 2.5 years of Triple P implementation in the Triple P system counties, while the other counties just coasted and did whatever they normally would do. Trained all kinds of service delivery agents in all different kinds of settings. And the Triple P counties at any given moment had about 85, the 9 counties, had about 85,000 families with at least one child in the target age range. And we ended up over that 2.5 years of delivering, we had a sort of a confidence range estimate between about 11 and 16% of those households actually had face-to-face delivery, which is pretty good penetration. And this estimate doesn't include media exposure. So we think we could have gotten even bigger penetration, but we knew that we were making substantial, and that, when I say we, the people we trained, none of our staff actually went in and met with families. We couldn't tell you any family that had services delivered. It was all done by these workers who had been upskilled in Triple P. Okay. We had 3 outcome variables, none of which were collected by our staff. These were from 3 different data systems. From the Child Protective Services system we had for each county over the many years, including going back 5 years before the study. We had substantiated cases of child maltreatment. From the foster care system, we had child out-of-home placements, which were predominantly foster care placements, some kin placements, but mostly foster care. And then from the hospitals, as part of their normal reporting every month of everything they did, the analysts for the state were able to help pull out the maltreatment injuries that resulted in hospital or emergency room visit. And so those are the 3 indicators. We went back over the 5 years prior to the study and found that all 3 of these variables had stable pre-study baselines, and that the 2 clusters of counties did not differ in that 5 years prior to the study. That's important. When you only have 18 units, you've got to be really careful about watching for unusual trends of 1 or 2 counties and throw the whole system off. And then we still controlled for baseline level for each county. So it's like compared to their baseline, how were they doing after they were exposed? Here's what we found. For out-of-home placements, the triple P counties showed about 16% lower rate of foster care placements, which was significant at 0.01. In child maltreatment injuries that were hospital treated, 17% lower in triple P counties, and substantiated cases of child maltreatment, which I consider the least important of these 3, and I'll tell you why in a second. They had 22% lower than comparison counties. So all 3 of these systems showed that the triple P approach, which by the way had nothing to do with child maltreatment, it was about just strengthening parenting at a broad level, could produce some impact on these objective indicator outcomes at a population level. Now, the reason why I think the substantiated cases are less important than the other 2, substantiated cases have some subjective element to them and are more prone to, when workers get stressed and the caseloads are too big, the criteria for that could change. Or if workers are laid off and there are fewer people to actually do the substantiations, the rates could change as a function of that. Now, granted, we had differential change between the 2 conditions, but that's a little bit softer criteria. Out-of-home placements, the state doesn't want to pay for an out-of-home placement, and they try to avoid it. And if they're avoiding it in 9 counties and they're not avoiding it in 9 other ones, and it's a function of, it's predictable by which ones got the triple P and which ones didn't, that's pretty good evidence, because the state would have loved to just knock down all out-of-home placements. And by the way, we looked at all 46 counties in the state, and there was no trend in the direction of the triple P counties during that post-intervention period. So it's not like these 9 counties were similar to some other counties in terms of they just happened to go down, wasn't it? They were bucking the trend after they were exposed to triple P, but not before. And then injuries, the hospital workers don't make up the injuries, they just report whatever happened. And the maltreatment injuries are all mixed in with all the other kinds of injuries and diseases and everything else that doctors do. It's just routine record keeping. It's pulling that out without it having been called attention to at the hospital. So I have those are harder outcomes and also expensive outcomes. Now, caveat, just because parenting and family support for child maltreatment prevention is helpful doesn't get us out of the trap that we don't have to do anything else. We still need to address food and shelter issues, healthcare issues, education, employment, and we still need high-quality substance abuse treatment services. So just because you take a population approach to parenting and family support doesn't mean you can neglect all the other variables that are going to affect the well-being of children and families. So it's not meant to supplant that. However, it is meant, I'm not presenting any cost data today, but it is meant to have a system that you can get out to a large segment of people in a cost-efficient way. If you took one of our standard kinds of parenting programs and deliver it to all the parents in the community, you'd spend millions of dollars more than what was spent in order to do this. I won't give you the data today, but Steve Ayos and the Washington Institute did an analysis, and they saw it was a very good return on investment of this trial. They analyzed this trial. Lessons learned. First of all, why invent new systems? Make use of existing workforces across agencies and organizations. Just knit them together by a common set of procedures and intervention strategies without having elaborate memoranda of agreements. You know, a host agency or or you can have a multi-agency host can draw together several sectors of service delivery personnel without housing all of those agencies under the same roof. It's important for managers, we learned this the hard way, for managers and supervisors to have intensive briefings before ever training professionals. We were in a hurry to get moving because the clock was ticking on our trial, and so we had to try to orient managers very quickly. And I would suggest to people who are disseminating to allow more time for the managers and supervisors to really get comfortable and understand what they're getting into so they can orient their staff. The last point, I'll skip the last point there, there's a need to over-represent the lower intensities of triple P, not the higher levels. I don't have the pyramid I like to show, but the pyramid is essentially, at the base of the pyramid is the media. If the pyramid represents the whole population, the bulk of that triangle, that pyramid, is media, no face-to-face. So substantial numbers of parents can be reached that way. Then comes these low-level, levels 2 and 3, that you catch much of the families. And then at the very top is level 4 and level 5, so that you narrow your reach of the more intensive. We tend to do either the opposite, or we tend to ignore the lower levels and just have a rectangle where everybody gets a lot or they get nothing. You know, and that's not a population public health strategy. Finally, I'll just make a few other points that it's important for communities to lay out a multi-year blueprint. They may not be able to adopt an entire population strategy in one go, but they can set up steps to do that. They should commit to an integration of the media strategy, but not first. You get the people trained first, and then you bring in the media stuff. It reinforces parents and practitioners for what they're already involved in. And you need to build a commitment to quality assurance, and there are several pieces of that I won't go into today, but I'll just note that there are elements that need to be in place for quality assurance. On that note, I'll take questions. Yes?
So you said this is not based on recruitment. I'm just wondering how you got the parents engaged in this program, and also finding, you said it was found effective in diverse cultures and diverse populations. I'm just wondering how that was implemented.
Okay.
And Ron, can you just repeat the question too, since we're videotaping, to make sure that people who watch this.
Okay. Well, the first question is, how did parents get engaged? In terms of the conducting of this trial, we didn't recruit counties. We simply went into counties and started talking to agencies. The agencies themselves and the parents and the family and the practitioners in those agencies used Triple P as their vehicle, their tools, but they engaged parents in the many ways that they would normally engage parents in those agencies. And we had, by the way, even clergy who were trained, who had pastoral counseling backgrounds, because in some of the African American communities, the church was where parents went when they were having a difficulty, certainly not to mental health or some other kind of agency. And so how clergy would engage parents is the parents would approach them. So we didn't try to interfere with the normal ways that workers in their various settings would engage parents. We just gave them a more flexible set of tools that linked also to other things that are going on in the community. Your second question, just give me the one word there, the culture.
Yeah.
Okay. In terms of this trial, I mean, I should mention that the 100+ studies have been conducted in a number of different cultures, a number of different countries, and so on. But I'll speak only about the population trial for a minute. About 35% of the practitioners we trained were African American. And that pretty much matched the percentage of African Americans across the 9 counties where we work. Now, one of the things we did after a couple of months of these practitioners having been trained, we had them rate their satisfaction with Triple P as a program. And all the practitioners, on average, rated Triple P pretty highly. But interestingly, the African American practitioners rated Triple P slightly higher than the European American based practitioners. Now, you might say, well, why does that matter? Because remember, we didn't have contact with the parents, we had contact with the practitioners. Why that matters is that many of these practitioners were parents themselves. And if they thought the program was inappropriate culturally for their own family, within their culture, they wouldn't have given it an even higher rating than. And these were where the names were not on the rating sheets, and it was group. These were aggregated ratings. So that was one piece of evidence. The other thing is there were plenty of African Americans represented in the prevalence rates of child abuse. I would say poverty was a bigger correlate of child abuse outcomes. And African Americans may have been overly represented amongst, because they're maybe in South Carolina, they're overly represented among impoverished groups, then they might have, by that factor, been overrepresented in the child abuse data. And we have no reason to believe that the data affected African American families less well. In other words, they contributed to the prevalence rates and the reduction in prevalence rates. Good question.
I think to follow up on your response to the first question, I'm kind of curious if there was any unintended impacts on the way people conducted business outside of just how they're interacting with families. So maybe child welfare organizations changing policies or procedures or anything like that, just based on their Triple P training.
Okay. The question is, were there any unintended either benefits or problems? But one of the benefits that we observed was we would train people from different organizations and different disciplines and different agencies in the same training room. There'd be 20 practitioners in the room, and they would come from different parts of the county. In fact, sometimes they even come from another county, but mostly within their county. Some of these people never met each other from other agencies. We never had any memorandum of agreement between or among agencies. But what we found is that we were getting reports from practitioners over time is that they were...
No more.
They were cross-referring. They were getting together and talking about shared issues between agencies. So it was creating an informal network amongst the agencies without trying or making people do that. If you'd gotten everybody to go to a meeting, you wouldn't have, all the agencies, they go, yeah. But in this case, they're all working on a common goal, and then at the break or at lunch, they would chat, and they would find out they could help each other. So, and this was without any elaborate programming. Yes?
Did you collect data that might bear on the possible criticism of treatment as usual comparisons of saying that your treatment delivered some of the treatment as usual plus the additional component as opposed to replacement of treatment as usual? Do you get that?
Well, we don't really know what went on in the other 9 counties, in the comparison counties. Right? And so we're not sure whether it was the parents weren't getting any kind of program at all, we could speculate, there could be just the same things that, there's no reason to believe that prior to our study, that the practitioners in the comparison counties were doing anything different than the practitioners in the ultimate triple P counties prior to our study. So what we're not sure of is, did they replace non-evidence-based strategies with evidence? Probably, because most of these people had no training in evidence-based programming. We did have a little bit of background about that. Did they now look for ways to help more parents because they had tools that they were proud of? Possible. So there are some unknowns here. But there are data from other countries that suggest that these are practical, triple P is practical strategies that don't require long commitments to each family, whereas some of the other programs, both evidence-based and not evidence-based in other countries and other communities, make too big of a commitment and use up the time of the staff, and so you can't reach as many. That's more likely, is that they're able to reach many more families in a more efficient way.
I think we're gonna have to finish. I know, unfortunately, I think there's another class that's coming. I'm sorry. But we'll have another opportunity. I think you guys at least will have another opportunity to talk about here. But I just wanted to thank you very